knowledge transfer and exchange for all issues affecting care of the elderly. And we have over 1,500 members worldwide. And one of the issues or areas of care that they look at is the end of life. And Chris Klinger, who's seated there before you, is on that theme team for end of life with NICE. And so we'd like to thank NICE as well. And the Toronto Central Palliative Care Network, we'd also like to thank. Subi is here today from the network. And they are working hard to make this end-of-life experience a very positive one for people at their lives. So thank you all for coming. Chris is going to start by giving us a little overview of palliative care at World Hospice Day and the issues that are doing with And Chris is one of our students in our collaborative program. The Institute has a collaborative program in aging, palliative, and supportive care across the life course. It's a nice long name. It has two streams, and palliative and supportive care is one of them. So Chris is one of our doctoral students in the health policy management and evaluation program here at U of T, and a very active individual. And so he's going to begin, and then Ms. Jenny Frank from the UK, who has very kindly and generously offered her time to come here today and speak with us, will have her turn to give her views and experiences on what's happening in the UK. So thank you both very much, and we will begin now our webcast. And I'm just going to go over here to the camera, and Chris, you can take it away.
Great, thanks so much. Great, well thank you so much for the introduction, Susan. I really appreciate the opportunity to be here today on behalf of NICE, the National Initiative for the Care of the Elderly. And it's a great pleasure to have a guest from the UK actually speaking on this very important issue of caregiving on our occasion of World Hospice and Palliative Care Day. I've been tasked just today to give you a very short overview about World Hospice and Palliative Care Day and the developments of international hospice and palliative care today. I'll just really take the next 12 minutes or so to give you a very short overview about what is happening internationally. I'll talk a little bit about World Hospice and Palliative Care Day. A lot of you are familiar with that one. Just to give you an update of what is happening, especially around the world. And then I'll talk a little bit about international issues in hospice and palliative care. Some of them which are the same issues in Canada, and I'm guessing also in the UK, especially with regard to caregiving. Mapping the levels of palliative care is an initiative that was currently undertaken by the International Observatory on End-of-Life Care at Lancaster University in the UK. And they've taken it up actually to really map the world in terms of what is happening in hospice and palliative care. And then there's also national associations and standards and guidelines of practice, which are potentially one of the components that are so important in national strategies towards end-of-life care. And finally, all of you have probably heard about the Economist Intelligence Unit issuing a report of the state of dying and death internationally, and also ranking some of the countries to see where they fit into the continuum of hospice and palliative care. And although it's a little controversial, you see that Canada actually came out quite good in this report on a ranking of 9. And I'll just highlight some of those issues and just really talk about that a little bit, because it also pertains to the discussion about the role of caregivers and caregiving inside those countries. So just to start out, many of you are familiar with that one, and that's just like the introductory slide of the World Health Organization about hospice and palliative care internationally. And it's an approach that really deals with all the things that are connected to death and dying, and really also talk about the treatment of pain and other symptoms from a very holistic approach, so physical, psychospiritual, as well as spiritual. There's another definition, though, that is brought forward by Dr. Stephen Connor, who's now chairing the Worldwide Hospice Palliative Care Alliance, and he pretty much talks about care that is provided for people facing death by people unafraid to face death. And I think that's really highlighting the role of caregivers and people involved in end-of-life care towards this extent. So World Hospice and Palliative Care Day, what is it actually? It's an international day of action that really tries to draw attention to hospice and palliative care and to the care that is taken at the end of life for the people from the time of diagnosis all the way to death and bereavement. The vision is to increase the availability of hospice and palliative care services throughout the world, and actually also get the word out about the things and the work that's done by the professionals in the field. This year, our theme, and this has been highlighted a couple of times, is sharing the care. And that's actually really one of the issues we're trying to do also here in Toronto, sharing the care between all the provider organizations involved in end of life and in hospice palliative care throughout the continuum. And there's the website again if you're interested to learn more about this. It's worldday.org. So what has been happening over the last couple of years is events have been happening all over the world in connection with the different themes. And there's been a lot of lobbying going on also on the political scale to try really to get attention to hospice and palliative care. Last year, 2009, was also a year when we did Voices for Hospices. Some of you are probably familiar with that. An international row of concerts that are actually trying to get attention to hospice palliative care. And if you see that last year, they had about 395 events in 74 countries, which really shows that the population is growing and there is more uptake for hospice palliative care internationally. You see the distribution: Africa 10%, Asia Pacific 10%, Europe still biggest 66%, and the Americas with about 12%. There have been 311 Voices for Hospices concerts, and there's also the uptake. Oops, not counted here. So we have about 250,000 people now engaged in these events, and this wide media coverage, which is such an important thing. And the BBC, again, the British leading the way here, have actually really included some of that coverage and footage of World Hospice and Palliative Care events. And some of you might know that even the marathon in London is sponsored by Help to Hospices, which is the local charity for hospice organizations there. There's definitely been also uptake in messages of support from some of the people that are really world famous. Some of them are Desmond Tutu, Archbishop Tutu from South Africa, as well as Judi Dench from the United Kingdom. And also in Canada, some of the people have spoken out very prominently about this. Larry Lieberg here in Toronto, definitely one of the leading physicians in the area, as well as a couple of others. So in terms of statistics and reports, I just really wanted to highlight some of those achievements. And access to pain relief is definitely one of the most important issues that are still facing in terms of hospice and palliative care service provision. But there's also an increase in volunteering, which is very, very important in terms of the caregiving at the end of life. And we're also seeing more and more interest of other healthcare professionals in the area of end-of-life care. And I think that is very, very encouraging. And this not only goes for the medical profession, but also for the allied health professions, as well as all the other professions that are involved in end-of-life care as part of the holistic team that is involved in that. Just in terms of the international development update, I just really wanted to talk a little bit about the projects that are happening right now and about the mapping especially that is going on in the UK. And what they're trying to do is they're really trying to figure out what is happening in some of the countries worldwide in terms of hospice palliative care service provision, but also in terms of the care that is taking place in those. They have developed a template actually to really try to map those activities, not only to really register some of the services that are available in terms of palliative care wards in hospitals, as well as hospice services throughout the community, but also trying to figure out what else is happening in the community, how is volunteering taking place, who is actually involved in hospice palliative care, and also what is happening actually with young caregivers and people like that. What are some of the issues that are faced with those ones? And what they've done is also they've tried to conduct a lot of interviews to really find out what is happening there, and then also try to give resources for the people in those countries. So if you're looking for services, where can you go? And actually, if you're trying to look up for pain management, for pain consultants, what is available there, and what is the easiest way to access them? Because the access issue is definitely one of them that they're facing all across the world. And finally, policy and service development is definitely one of those actions. I don't know, you're probably familiar that Canada now has a parliamentary committee that is dealing with palliative and compassionate care. So there's definitely a lot of political interest in this area as well. And it's one of the things that we're really trying to promote also as the sponsoring agencies of this talk, to really make sure that there's political uptake in the area of end-of-life care. Because Canada itself will have problems with aging, and there's definitely going to be more and more people dying in Canada, and they all are really in need of good hospice and palliative care. So just showing you the world map is giving you a little bit of impression about what is happening worldwide. And it's really just setting out this way so that you can see that the countries that are mapped in green are the ones where there's good hospice palliative care service provision, with Canada definitely being one of them. But the red is all those countries where there's no activity at all. So there's just some localized provision, but the question really is what is happening in those countries and what is taking place there, as well as with the yellow ones where there's no activity at all. And that's definitely one of the questions that we're asking. Why are they also clustered like that? And why are things happening this way? Definitely, if you look at Africa, that's definitely one of the continents that has to catch up with hospice palliative care, despite all the problems that are there with other diseases, especially if you look at the AIDS pandemic and stuff like that. But it's definitely something to look at. Just to draw a little bit more attention to Africa, the UK also has published a couple of books about hospice palliative care service provision in those African countries. And there's a lot of interest at the International Observatory. Michael Wright and David Clark are actually affiliated with that one. And they've looked very deeply into hospice palliative care service provision in those countries. And you can see in green, just with the exception of South Africa, Kenya, and Uganda, that actually have policies towards service provision and that also allow for the importation of potent drugs, especially opioids, for pain management. The situation everywhere else is very, very dire. Zimbabwe has political issues right now, so we're not quite sure what is really going on there. It's still mapped green in this report, but we're not quite sure about that. But there's definitely one thing that is really, really interesting, and that's the connection between the availability of pain management drugs and morphine and opioids with hospice palliative care service provision. And if you just see those two maps now, if you just go on and try to link them together a little bit, you see that actually those two totally overlap. So the importation of painkillers is really, really important. The availability of those medications is very, very important. And I think the world actually also needs to put a little bit more pressure on the International Narcotics Control Board to make those painkillers available in those countries and to also allow physicians to actually prescribe them. That's one of the really large issues in those countries, and that's something that needs to be dealt with. Although we know that drug control is very important, there needs to be a mechanism for those people to actually access them. Namibia, for example, is now trying to get this done. They are not powerful enough as a nation to do that, but they've signed agreements with South Africa, which is their neighboring country, for the importation of those drugs. And there's now the opportunity to actually get some of the painkillers available in Namibia. And I think that's potentially a first step. And if countries can cooperate, that might actually lead to this graphic changing a little bit and potentially us seeing a little bit more green in the future. Just really wanted to highlight other talks that are going on with that one. Malawi is one of the areas that we're also looking into, and Ontario has a partnership with Malawi, so that's why we're interested as Ontarians in actually what is happening there. And there's going to be a next talk by Sandy Butchin with the Toronto Palliative Care Network, especially on hospice and palliative care service provision in Malawi. So if you have an opportunity to see that, that'll be great, and you can get more inside information about what is happening in Africa. On the other hand, the International Observatory, and I'm sorry for the at least a little blurred picture here, is they're going to release a book. It was supposed to come out in January. I'm not quite sure whether it's actually out yet or not. But this is also really monitoring the situation in South Asia. And I think that's an interesting case as well, because we also have the importation problems for drugs in those countries. And that might mirror potentially some of the situations we've been facing in Africa. I just really wanted to highlight some of the availability issues that are going on with national hospice and palliative care organizations, because we think that one of the really champions for hospice palliative care service provision is at least the importance of an infrastructure to be in place to actually talk about those issues, but also to deal with things like the importation of drugs. So national hospice and palliative care organizations might be one of the cornerstones to actually get this done. And we've just really mapped out what is happening internationally. And you can see we had hospice and palliative care events last year in 4 countries, so 75 countries. But yet you have at least organizations now in 69 of them. So there's definitely a movement upwards. 20 of them actually have guidelines and standards to care, and we think that that's another very important step, because quality control is also very, very important, and also training opportunities, especially for volunteers. So we're thinking that this is definitely a way to go. And as you can see, on the other hand, the medical specialty is also one of those issues, because we want hospice and palliative care to be the mainstream, to be integrated in medical care as well. And 18 countries have now actually really done that, with the United States now also coming on board and having hospice palliative care medicine as a subspecialty within some of their medical boards. So I think we're thinking that this is actually going in the same direction, and Canada is actually also pushing the same way. Toolkit for national associations is also one of those things, especially with the importation of drugs. So we just had some of those ideas, and we were kind enough to actually get some funding from the Diana Princess of Wales Memorial Fund to do a study on that and to develop a toolkit that will help national associations to actually set themselves up and to get an interaction with politicians and also with international organizations to make sure that hospice palliative care can be provided in a lot of other countries. Standards of practice, and I just list where those 20 countries are again, a lot of them in Europe, European countries really leading the way. There's definitely the United Kingdom, again, one of the leading ones. But you also see there's more interest now in Asia Pacific region with Australia, Japan, New Zealand there, Singapore as well as Taiwan. In the Americas, only Canada and USA have actually achieved standards of practice yet. So we're really looking forward to more of the Latin American countries to come on board. And in Africa, we see South Africa and Zimbabwe right now, but we're hoping that there will be more action, especially in Namibia, that is really moving forward in this regard, and also Uganda, which is one of the leading countries. Uganda also being very interesting in this regard because they have achieved importation of hospice drugs into the country through the international agencies, and they also have prescribing rights for nurses in terms of hospice palliative care medication. And we think that this is very, very helpful alongside a really, really good volunteer force. You see that there's a lot of interest in actually those standards. 28 countries have indicated that they're interested in developing those standards, and the Worldwide Hospice Palliative Care Alliance might be one of the avenues actually to achieve that by sharing some of the international knowledge. And Canada definitely also has a lot of knowledge with regards to establishing guidelines of practice. But the barriers still remain, and you'll see that some of those barriers might look very, very familiar with you if you're practicing here in Canada. There's really insufficient training in numbers of professionals in hospice and palliative care. There is definitely insufficient funding, just really repeat that, like insufficient funding, because that's definitely one of the things that need to be in place to make sure that things can happen. There's difficulty in service provision, especially in rural and remote areas, very important for Canada as well. So it's very, very difficult to access those services if you're just not good in the mainstream, like Toronto. There's pain medication issues. I've touched on them a couple of times. Really, really important to talk to the International Narcotics Control Board about those. And the other issue is the cost of drugs, because those drugs are prohibitively expensive to import, especially for poorer countries. And that's definitely an issue where some international movement needs to take place to make sure that everyone gets access to those drugs. Finally now, the Economist Intelligence Unit report. That's one of the things that I've touched on a little bit in the ranking that they've actually done. And what you see is they've tried to actually come up with an index for quality of death. And this is comprised of 4 components. So they looked at basic end-of-life care environment in the country. They looked at the availability of end-of-life care services, mostly medical services in this regard. They looked at the cost of end-of-life care, the cheaper the better, and then the quality of end-of-life care inside the country, and tried to really come up with an index to rank countries internationally. And they've also done some key informant interviews with leaders in the field, especially with national organizations, as well as politicians in the field, to see where things are headed. So in the ranking, you can see on the left-hand side that the UK is actually positioned at number 1, despite the fact actually that they didn't do that well in terms of doctor-patient transparency and the question of actual healthcare service provision. But the important thing here also is to see Canada's ranking right there up with the United States of America on position 9. And that is a very encouraging thing on one hand, because it really shows that hospice palliative care is talked about in Canada, and that there's really movement towards hospice palliative care and better hospice palliative care. On the other side, if you remember Sharon Carstairs' report on hospice and palliative care, we're still not there yet. So we're still trying to make the argument that we're not there, that a lot of the things that we're really fighting about, especially in national end-of-life care strategy, have not been implemented yet. And that's something we really need to get going in order to also get a better ranking in this report. So just take it with a little grain of salt here. There's a lot of public debate, and that's some of the things that are sort of encouraging as well, because I think it's good to see that there's movement, that people are actually starting to think about that. But it's also a very loaded debate, and I think that's one of the things to always keep in place. Physician-assisted suicide is one of the things, euthanasia is one of the other ones. And you've seen what has happened in the US when they were talking about just a little bit more money for physicians to have a discussion about advanced directives. It was labeled as the death panels, and that's just really not what this is all about. This is not the direction to go. But I think there's at least an opportunity to start the talk, and I think as that, this is actually a good thing. Drug availability is definitely still one of the practical issues, and that's one of the things also to take in mind with all the discussions that are now taking place about OxyContin, putting things on registries, really labeling things. the thing that we really need to push for is access to those drugs for the hospice community and to make sure that those drugs stay available. There's shortages now in the United States for a lot of those drugs because of FDA policies, and I think that's very, very critical to keep in mind and to monitor as we're moving ahead in Canada with hospice palliative care policy. So a good report, definitely very, very important, especially in terms of the government recognition of hospice palliative care, but still way to go. And I think the key message, and that's my final point here, is actually the push for a national end-of-life care strategy. Because that would be a strategy that grinds and really enframes all the issues we've been talking about and would give Canadians a right to access to 24-hour care 7 days a week. And I think that's a really, really important issue. And again, the UK has led the way because in 2008 they implemented a national end-of-life care strategy. And I think that's really a pointer for Canada to take as well. And then we might actually be able to overtake the UK. That's nothing. So hey, there's options and opportunities. So just on the final point, I wanted to thank you all. I wanted to thank all the sponsors for actually making this happen. And I wanted to end with the vision of the National Hospice and Palliative Care Organization in the United States of America for a world where individuals and families facing serious illness, death, and grief will experience the best that hospice and palliative care can offer. And I think that's something to really go for. So in terms of the questions, I think we can hold them until the keynote presentation, and I will move it over now to Jenny to talk to us about some of the strategies that they're doing in the UK to be number one. Thank you.
Let's get the technology sorted out. Before I start, I just think the world is a very small place. I'm just delighted to be here to share the learning that we've got. But we do get supported by Judy Dench, the Children's Society. So Judy Dench is obviously a very busy lady.
She is.
And we do get funding from the Princess Diana Memorial Trust. So lots of commonalities there. So thank you. Well, thank you so much for inviting me. It is a real pleasure to be here and hosted by Hospice Toronto. Thank you. It was, as I was sitting there listening to all the international initiatives that Chris was talking about, I just thought before I start my presentation, I'd just share with you some of the international links that we've got, because there's some real crossovers here. And so, Chris, I'd like to maybe spend some time talking to you afterwards. I was fortunate enough to come to Canada in 2006 and actually meet with some young caregivers down in Niagara, and there's now a piece of work developing there. So I'm particularly pleased to be back here again and seeing the momentum is continuing with Hospice Toronto. But I've also been fortunate to travel to New Zealand to help set up some support there for young carers, but also to Kenya and to look at the issues in sub-Saharan Africa with the orphans and vulnerable children that are caring there for family members with HIV/AIDS, and of course getting linked into their palliative care programs. And we have really, really strong links with Kenya, and we're hoping to go back next year and have a second international forum over there. And so I think there's a real opportunity here for some shared dissemination and learning. So we must talk about that. And that's funded by the Commonwealth Foundation, and we sponsor Commonwealth students to come along and shadow us. But of course I was sitting there thinking, well, I'm sitting here in Canada at the moment, and my team are back at home busy holding the fort, but they actually have a visitor from Japan who's come across to learn about the work. So I think there's a real synergy here about international learning, and I just wanted to share that with you before I start. Okay, I'm going to refer to my notes simply because I don't want to get to the end and realise I've forgotten to tell you something vital. So excuse the rustling of paper. First of all, I'm Jenny Frank. I work for the Children's Society, and I have been involved in raising awareness on the needs of young carers, young caregivers, for now 12 to 15 years. I am also a carer myself. I have a 25-year-old daughter who has a severe learning disability, so I can say I know firsthand very much what caregiving is all about and how it can impact on the wider family. I have a husband who is in the military.
Jenny, Can I just ask if you speak a bit louder?
A bit louder.
People are having trouble hearing on the
Okay,
internet.
I can do that. I have a husband who is in the military, so he's often away a lot, and 2 other children. So I'm well aware of the impacts on the wider family firsthand. Is that better? Can you hear me now? Okay. Also, I am a member of the Government Standing Commission, whose role is to actually monitor the rollout of support to carers nationally across the United Kingdom. That is a personal appointment, it's not an organisational one, and there are 20 of us who are members there and bring our own expertise and learning to that group. And I'm going to talk to you a bit more about that later. But that's just a bit about who I am. In the next 35 minutes, I'm going to try and give you an overview of what young carers issues are like, and also some of the initiatives that we actually have evolved in the UK, many of which, in fact all of which, I think are eminently transferable to whichever country we might be working in. This piece of work that's being launched at Hospice Toronto is growing out of a need to recognise young carers in end-of-life situations and palliative care situations. Our work too started way back in 1996, looking at the needs of disabled children who were severely disabled, chronically sick, and also had short life expectancies. But you'll see that it's grown into far much more. So let's see where this model takes us in Canada. It will be exciting to watch it grow. It's going to be a bit of a gallop, but I'll do my best to cover as much as I can, and then we'll take questions at the end. So, more by chance than design, we actually have a legal definition of young carers, which was set way back in 1995. When I say more by chance, this was a piece of legislation that was designed to support adult carers, but literally 48 hours before the Act went through Parliament, the MP pushing it through met with some young people aged 15 and 16 who told them what life was like for them as a young carer, and last minute the bill was actually reformed to include children under 18 who were caregiving. So they were very firmly in there, but I have to say it's a recognition act. There weren't many services attached to it. But it did define carers and young carers, and actually reminded us that the person receiving care is often the parent, but can also be a brother or sister, grandparent or other relative within the family, having a chronic illness, mental ill health or life-limiting condition, connected with the need for care, support or supervision. And also in UK we include parental alcohol dependency or drug misuse. So you can see already that's a large number of the population. So I'm aware that the model over here is starting off small with palliative care, but I can see that it's going to be eminently transferable to families that we work with across the country. And so what do these children do? Well, anything that an adult carer might do, really, that's needed in the family home. So your general cooking, housework, shopping, lifting, helping with physiotherapy, dressing, washing, helping with very personal care needs. And we have boys who are looking after mums, so 13-year-old boys looking after their mum's personal care, and equally girls, some as young as 8, 9, helping to look after dad's personal care or brothers or sisters' personal care. So cross-gender caring at an age when maybe it is totally inappropriate. Giving medication, that's a huge debate about whether children should be allowed to handle and give medication. And also then managing the family budget, actually being mindful of the financial resources and going out to collect prescriptions and benefits for the family. A big one for many of our young carers is actually, if the parent is too sick or disabled, is actually helping to look after or parent younger brothers and sisters. And the big one is about giving emotional support. So all those first ones, those first bullet points are really quite visible. You can see them if you look hard enough. But what the young people say they find really hard to deal with is the emotional care. So often they say, well, I don't mind having to do all the other things, but what I really can't cope with is the worry, the anxiety, that I have to deal with, and there's nobody to talk to, nobody to share my worries with. And then, of course, for our migrant communities, and we call them migrant communities in the UK, and I hear you call them newcomers, which I think is such a positive word. That's something I'm going to take home with me. I'm going to launch a single-minded campaign to change our terminology. We are acutely aware that there's a lot of interpreting carried out by children where the parents' language is not English, and they often have to interpret pretty hard-hitting medical diagnosis and care needs. And is that appropriate for children? I think absolutely not. And we also have interpreting being carried out for partially sighted parents, parents that are blind, and those with communication difficulties as well. Children actually get called upon to carry out those roles. So you can immediately see this is a very long list, and we're talking about children. So in UK we've done large pieces of research. Many of you may be familiar with Professor Saul Becker's work. He and I work very closely together on various projects, but he has been instrumental in actually acknowledging what the impacts are alongside other researchers as well. And this is a summary of the key impacts upon the children that have been identified, and is echoed on a daily basis by all the young people that I meet with. So I guess number one is problems at school, attendance, not being able to concentrate, but also have their own health problems, fatigue, tiredness, possible back problems from lifting, isolation, huge sense of isolation. Is it only me? Is it only my family that is like this? I would just so love to meet somebody else in the same situation. Just doing that would really help a lot, to know I'm not alone. Not having a chance for leisure, inviting friends home, the feeling different, and then of course the big one, pressure from keeping family problems a secret. Often, particularly in issues where there's parental mental illness or addiction, these children know it's maybe not something that should be talked about outside the family home, and are reluctant to go and ask for help or to share anything. Huge sense of loyalty. And then the lack of being invisible. Care can be put into the family home, but often the role of the child goes totally unnoticed. I'll touch on that again in a minute. And you notice that I didn't mention emotional difficulties, because it's all wrapped up there in the middle of that impact. But again, they actually say that's the bit that's hardest for them to deal with, and we need to hang on to that because it's so hidden. So I showed you the definition at the beginning about the regular and substantial care that was produced in 1995. We are now all working with a new definition that was drawn up just recently. It's not in law yet, but we're hoping that it will be soon. So actually putting it back to the individual. So actually not, instead of looking at how often they do it or how heavy the caring is, we're looking at how it affects that child, because every child is different, every family environment is different. Some have really good coping and resilience mechanisms, and others will just crumble at the simplest task or the simplest emotional challenge. So we want to put it back to looking at the individual needs of the child. And so we're looking at defining the needs of a young carer as when they become vulnerable, when the levels of responsibility become excessive or inappropriate. So there you go. It's not just the caring that affects you, it's the worry of it all that they say. So here are some common themes that I've drawn out. Now this is from my international work, so travelling around to various different countries, including Europe. These are the themes that we have identified that the young people have said that they're feeling. And I'm just sharing this with you because I think it can't be that the young people in Canada are any different. So if we're looking at some commonalities and starting point, it's going to be the same. So the worry, the guilt, the loyalty that we talk about. A sense of anger. Why me? Why my family? Why does it have to be my mum? Why my brother or sister? And often that sets up a real conflict of emotion in loving the parent, loving the brother or sister, but hating the illness and the situation that it's put the family in. and then it obviously bounces back to them feeling guilty. Big one here, issues of codependency and the child becoming the parent to the parent. So child's been at school all day, wants to come in the door. Usually mum, dad will say, "Oh, did you have a good day? And what did you do?" And the pupil will usually say, "Well, nothing." That's what they say. "Didn't do anything today." Don't want to share it. But instead, the young carer comes home and the parent that's ill isn't coping, is maybe suffering from depression, or is aware that they've got a very serious illness, and they just need to talk to someone. First person through the door is their son or the daughter, and they want to offload on them. So total role reversal there. Something that the children feel quite hard to deal with. Also, these children, no matter what, even if they're not caring for someone who has palliative care needs or is at end of life, a sense of loss, the change in the illness or the disability can change their family member forever. This first quote is a mother that was involved in a road traffic accident and as a result had a brain injury which affected her personality. So she came home, looked like mum, dressed the same as mum, wasn't mum. Her personality had changed completely. Huge sense of loss and grieving. Where's my mum gone? It's not this person that's come back from the hospital. So helping the child to cope with that truly. And then of course, active dad who used to go everywhere with his son and now he can't even get out of the house. So huge sense of loss. And then the work that we did in the early days with the children with disabilities, with their brothers and sisters, the grieving, the sense of loss, that yes, they had a new baby sister or a baby brother. They had a 5-year-old that was growing up alongside them, but it wasn't like other people's brothers and sisters. And so that the anxiety and the loss and dealing with that, and then the huge feeling of guilt because they were daring to feel that way and they didn't dare share it with anyone. And then of course for those children that are caring where it is end of life, they are going to go through bereavement. But added to that bereavement, if they've been caring, it's, what did I do? Didn't I care for them well enough? Didn't I look after them? Maybe if I'd done it this way, they wouldn't have died so soon. Was it my fault? And then of course for those young people that have been caring for some time, maybe a number of years, and then their family member dies, that loss of identity, the role, the responsibilities that they have been undertaking, they need support to work through that and to recognise that they have their own identity. So I'm watching the time here, but anyway, here's a quote that I think actually illustrates for us just how those young people are feeling and how hidden they can be. So this young person just kept missing school, just totally concerned about mum. Nobody had really explained to her what was the matter with mum or what was happening. All she could see that she was getting sicker and iller. If she's not getting any better, then she's obviously going to die. This mum actually had multiple sclerosis and was very poorly with it and wasn't responding to treatment. But this child was convinced that mum was going to die in a minute, tomorrow, next week. He didn't know when, but he had to get home from school to make sure she was still there all the time and she was okay. So there's huge anxieties that just weren't being picked up by anyone, certainly not by school. He was ending up being blamed and actually then being given detentions for missing school, in which he would sit and worry all the more. So you can see how hidden that situation can be. To talk a bit more about the support that we give in schools later, and if I forget, please somebody ask me that question at the end. Some other common themes that we found internationally as well, even when we were doing our work in Kenya, was the lack of access to education. So not being able to attend school because you were needed in the family home. And not just poor attendance, but when you're actually in the school, the lack of concentration. So just like that child on the previous slide, sitting at your desk, but you're not doing your work because you're worrying about what's happening at home. That leads to underachievement and then can affect your career choices and your future life opportunities. and the ability to access further education. And then for many of these children, so many of them say that they face stigma at school and get bullied for two reasons. One, because somebody's recognised that their family member is different. They might walk differently. If they've got a neurological condition, they may behave differently. If they have a mental health problem, then their behaviour may be different. They may have a brother or sister who is autistic or challenging behaviour, and they get bullied because of their family member's behaviour. And that in turn spirals into they don't want to make friends, they just don't interact at school. And then how do schools find out? Well, often only when there's a crisis. So this young person had been caring to such an extent that he actually fell asleep in class. And he didn't know that he could ask for help, and actually he really didn't know if anybody was interested. In the UK, we have a National Young Carers Forum, so young people that we have supported to speak out for themselves. And obviously I couldn't bring them with me, so the next best thing I felt was to bring some of their quotes with them, which is why I'm sprinkling my presentation with quotes. Just quickly now, I want to pick up on what the rights are out there for these children, and just to remind ourselves of some of the slides from the United Nations Convention on the Rights of the Child. So Article 2 actually reminds us that the Convention applies to all children, but it also includes, it explicitly includes a disability of a child's parents or guardian. So to be mindful of families where there's disability as well. So I just thought I'd put that in to remind us. And then of course, I hope that most of you will be familiar with these, and you've got them on the handouts. But it reminds us that children have the right to the best available education, that they have the right to live with your parents, and that parents also have a responsibility for the well-being and upbringing of their child, but that the state should provide assistance to the parents to help them. And so often in UK, we get tangled up in supporting parents that might be needy, lacking in parenting skills, and how do we support them, at the cost of forgetting where parents are ill or sick, that they may need additional parenting needs. So for me, that's a very important article that we need to be mindful of. And then of course, respect for the views of the child, freedom of expression, and the right to get and share information. And then a fairly contentious one, but I put it in there because it might generate debate. We all know that we shouldn't be exploiting children in the workforce, but sometimes are we exploiting children by expecting them to care at an excessive level? So maybe somebody might want to pick up that when we come to questions. So the next bit I'm just quickly going to go through is to look at why children are caring, what needs to change and what is changing in the UK, and the importance of us all working together, that actually supporting young carers isn't just something for children and family services or youth support, it's actually everyone's responsibility. So now somehow I've managed to give myself lovely fancy slides. So why are children caring? Well, in their words, I just do it. There isn't anybody else in the family to do it, so I just have to put up with it and get on with it. There's no one else to do it. Some people tell us we have a choice and you can walk away, but we can't. It's our family. Sometimes we feel trapped and it's hard. That was an 18-year-old who's been caring for some years and is desperate to get away to university, but feels that she can't. Loyalty to mum is too great. And then there's the other side of the coin. Mother isn't accepting how ill she is and the impact it's having on the family, so she won't accept any external support, but it's the child that ends up with it all. But for most of them, they've just grown into it, particularly where the illness is a gradual progression, so the caring responsibilities might be quite minor, and then before you know it, they're really very significant in impacting on the child. So other reasons why the children might be caring. Family structure. For quite a while when we first started the work in the UK, we assumed that all young carers were in lone parent families, and I can tell you they're not. Something like 54% of young carers are in lone parent families. So if my math maths is good, that's 46 that are in two-parent families, and they're often the very hidden ones. So there you see, dad looks after mum during the day, but when the children get home at night, they take over. So they can't stay after school, and they can't have friends around in the evening. It's the only way the family can cope. The nature of illness and perception and need. For us in the UK, this is really crucial because I don't know about in Canada, but we have eligibility criteria, and I'm not familiar with what your categories are, but we have, you will get care if your care needs are important because you are critically ill and it's at risk to your own life if you don't get care needs. You will get care needs if your illness is significant and your requirement in the home for support is at a very high level. But if they're just moderate or episodic, you are unlikely to meet our eligibility criteria. And for us working in the UK, where those moderate and significant boundaries are blurred, we find a lot of children are being relied on to provide packages of care in the home. And also, if you think about it, if you've got a child who's seriously ill, maybe age 12, who needs a lot of personal bodily care, which is quite heavy, and there's only mum at home, who's going to help her lift him 24/7? This will be the children, the other children in the family home. So the nature of the care tasks. And then they're tucked at the bottom, not deliberately, but it's in there, it's very important. Cultural expectations. Different families, different cultural expectations. Sometimes are children nominated to be the carer? Are they expected to be the carer? The flip side of that coin is for us as agencies going in, working with other cultures, is to be mindful of what they need to meet their cultural needs. Putting in a care support that doesn't respect their own beliefs, their own cultural family structures is not going to work. It's going to break down quite quickly, so we do need to be mindful of that. Crucially, lack of information. For a long time, this was huge in the UK, knowing that there was help out there, but also sharing with the child what's going on with my mum. If the children don't know, I can tell you, they'll make it up, and the image that they'll make up is far worse. A bit like that child worrying about mum going to die and rushing home from school every day to make sure she was there. There's a workshop that we run where we put all these headings up, and we ask people to think about why children end up caring. The one that ends up with the most post-its stuck to is the lack of effective and timely services. So it's not the family structure, it's not the lack of information, it's the actually we've not thought about putting the services at the right time of day at rush hour when the children come home from school when mum needs the most help, not at 1 o'clock in the afternoon when they're all at school. So that's the one where the post-its get plastered over that flip chart. And at discharge time, making sure that everything's okay before the patient's discharged. And I would guess that this is particularly crucial when we're talking about palliative care, when there's opportunities for respite, making sure that the family are ready to cope at home when the family member is discharged. A simple phone call could make all the difference. Just 24 hours later, how are things going? How are things settling in? Just ringing to check. And then the main, this is just reminding us, this is a cartoon that one of the children wrote. You can see they're all greyed out there, they feel invisible. They just feel that they get shut out with conversations with the social worker and the family. So they're there, they're giving all this caring, this emotional worry and anxiety, but nobody's seeing them, nobody's talking to them. For me, and I wrote this way back in 1995, for me, children haven't popped out of anywhere and started caring, but they are caring because somebody in their family has either unidentified or unmet care needs, and that's crucial. Going to move on now and talk to you a bit about the UK carer strategy. I'm very conscious of the clock ticking away. We have a number of pieces of guidance and legislation in the UK, but for me this is probably the strongest and the most important. I have to tell you it is only guidance, so that means you don't have to do it, but it has been adopted by so many people, and it has been very active in actually changing things for adult carers and for young carers. It was based on a huge piece of consultation which the Children's Society was involved in supporting young people to take part in. Lots of things were supposed to end up in it because of resources, funding, political issues. Some were dropped, but we kept every single one that the young people asked for, and I have to tell you, that's because I made sure the young people met the politicians themselves. It's incredibly hard to say no to a young person. So I think that my one big tip to you when you want to start changing things over here is always support a young person to have their say. They can say it so much better than me. So our overarching aim for our carer strategy is that children and young people will be protected from inappropriate caring. They'll have the support they need to learn, develop and thrive, and to enjoy positive childhoods. We have a document that was written previously in the UK called Every Child Matters, and so that's what that is related to. It also advocates action to ensure better joined-up support around the family, and vital, capacity building for staff. How can we expect all our staff to go out and deliver this if they don't understand the issues and know what's needed? So absolutely vital that's in there. Briefly going to actually let you know what this has resulted in. It's linked to two other key pieces of guidance. In the UK, we have something called personal adult and social care system, where people that are ill or disabled have their needs assessed. They are then given a budget to manage themselves, to buy the services that will work for them at the time of day that suits them. So if they want support at 4 o'clock in the afternoon when their children home from school, then they buy it for 4 o'clock in the afternoon, rather than 9:30 in the morning just after the children left for school. It's not as easy as that. I'm making it sound pretty. It does work though. It is working really well. And one of the key aims in that is to actually give services to the parent to sustain a family unit which avoids children being required to take on inappropriate caring roles. So you can see it's linking back to the carer strategy. Also in England we do have a very large issue around alcohol and drug dependency. And so our 2008 to 2018 strategy actually recognises that although we need to protect children in those families, we do recognise that if we can support the family to reduce its chaotic lifestyle, become stable again, then children should be placed with their family. It's the best place for them with the right support. So we aim to improve support to parents with drug problems, again so that children don't fall into excessive caring roles and be picking up the pieces for those parents. Out of this strategy, we have developed something called a joint working protocol. In England, our services for adults with disability, mental health, drug, whatever, are called adult services. Our services for children are called children's services. So where are families in all this? Well, they kind of go right straight down the middle. But it's getting a lot better, and we now have a joint working protocol which actually says adult services and children's services, you must not just talk to each other, you have to join up around the family to give a good service. And actually we're saying more and more, adult services, you have the responsibility for preventing children from caring in the first place by getting the correct services in the family home at the right time. Huge step forward. For years we've been saying young carers fall through the gap. At long last, I feel we're getting there. Huge amount of work with schools. They're absolutely crucial in identifying children. You can see from the slides I've just shown you. We've got training programs with staff and teachers, which I'm going to be sharing with Hospice Toronto. They're very busy people. Their primary role is to educate, but also they want to make sure that the child in their classroom is engaging and concentrating. So we help them to do that. We're just refreshing the strategy because we have a new government, and in that we are asking for our joint working protocol to not just to be a document, to be an active piece of practice. So we're asking for funding resources to take it out there to work with frontline workers and enable them to work around the family. And one of my final slides shows you how to do that. What we're also asking for, but most importantly, we're undergoing a bit of a change in the UK. We're a losing our primary care trusts, which Chris referred to, and we are setting up something called GP Consortia. I can't tell you any more than that because we're not sure what they're going to look at, but we are asking in our Carers Refresh to make sure that in every GP Consortia somebody has a responsibility for carers and adult carers, so when they are working for a patient, they actually are thinking, so when you leave my surgery, who's going to be looking after you? Have you got children? Do you want support for the whole family? So we're going to be asking for that. For me, I'm just flagging this up as well. This is another one of the tools that we've developed in the UK, and sorry, it is a screen grab, so it's difficult. But these are simple questions that we've developed in the UK. So if you're working with a family where there's an illness or disability, or where there's end-of-life care required, simple questions to ask. They're not rocket science, but I'm afraid that although UK is in the lead, sometimes these questions still don't get asked. Just ask, is there a child in the family? Are they helping? How can we help so that they can help at a level of caring which is acceptable and positive? So being loving, caring, son, daughter, making the most of the time that is left and having quality time with that parent, but not having to do personal care, the household chairs, chores and minding younger brothers and sisters. What needs to be put in place for that child? What do you need for the whole family? And what do you as a parent need? So you can still go out. Maybe you can't run with your son anymore, but maybe we could take you to the running event so you could watch and you could cheer him on, because that's what families are all about. It's about asking the right questions. And then you've got these slides in front of you, but you'll see that the other two slides refer to children with an illness or disability asking the right question. But we also say that in the UK, that if our children's services team get a referral for a young carer, so they have a referral come through to their team and it says this child has a need, they're a young carer, please support them, we say that should trigger a review of the family. So who is the child looking after? Obviously it's not working at home. Review the needs of the parent or the child with a disability. Let's increase the care package to reduce the impact on the child. And if we get it right, this is what our Government Department of Education is asking for our working model to look like, is to have the child's needs recognised and assessed, to meet those identified needs, and that might be through a group, such as the one that's we're hoping is going to be set up in Hospice Toronto. But at the same time, number 5, making sure that the family gets the support they need. So that the child just doesn't go out to the group, get the support they need and then go home and carry on caring, actually is an improvement in the home situation as well. So we get a circle of care. I'm conscious I'm running out of time. I've got about 4 more slides to go. So this is why I'm here today, because I'm so excited about the starting of the Hospice Toronto work. Why do we need group support for these young carers? Well, you've heard me talk. They feel isolated, they don't have time for play or leisure support. They're not recognised, they sometimes don't get respected or praised. There's nobody there for them. They feel they're different from other children and that no one else understands his or her experiences. Young Carers projects set up in the UK have built resilience for those children, built coping mechanisms, helped them not to feel alone, have given them back their childhood, have worked with schools to make sure that there are systems in place that they don't miss out on their education, being flexible about their study needs and meeting their deadlines. But more than that, it's just given them a sense of self-worth and a chance that they have a life too, and made sure that those important things in life about them getting further education are addressed and that they can move on. So I just so welcome the initiative that's being started here, and I will continue to do whatever I can help and share. But I just think it's such a good point to start to give these young people a chance to get together and share things. Peer support is such a strong thing. So there we go, in the young people's words. Just knowing that this group's behind you. When you're feeling a bit low, all you have to do is phone. You've always got people stood behind you, and they're caring for you, because they're doing the caring at home. Somebody needs to care for them. And then I have this wonderful video clip, and I'm sorry, technology is not my strong point. I wish I could have shown it to you. Of this young boy who sits there and he says, well, it's just when I talk to someone, it's just, well, it's everything that's inside me. I can get it out. And it's going back to that emotional need of needing to share things. So in UK, very quickly just to finish off, we've moved it all on. Having the voice of young people heard is crucial. We have a National Young Carers Forum. They're very well respected. They've been running for 3 years. I've made sure that every single politician knows about them. Our previous Prime Minister knew about them, and the new Prime Minister's got a letter heading his way. So when they want to consult with young people, have young people to deliver presentations, they call us up and we support them. They're placed all over the UK. So if it's Newcastle, we've got someone there. If it's Cornwall, we've got someone there. They're supported, they're trained in working with the media and also to deliver presentations, and we make sure that they are supported emotionally so they're not expected to do too much. They have informed best practice, policy and law. Their words are in our guidance, they're in our policy documents. The joint working protocol that I talked about is sprinkled with their words and sprinkled effectively, and they've just been interviewed by the Law Commission, where we are hoping to get written in law that children should be protected from inappropriate caring by giving the right services to the family member. That's going to be debated in Parliament in the spring, so we've used their words. We started off in the year 2000 with a Young Carers Festival, bringing together 400 young people to have a voice and to have fun and to have a break. And last year was our 10th anniversary. So 10 young people took a letter to 10 Downing Street to tell the Prime Minister that they were having their festival, and they wanted to make sure that he was going to make sure their voices were heard in the forthcoming Law Commission review. So I can't tell you how important it is to have the voices of the young people at the forefront of everything we do. And it empowers them to have a say because they know what the situation is. You'll not be surprised to know that my background is in youth participation. So anyway, the final 2 slides. How can we all work together? I haven't had a chance to know where you're all from, but I just wanted to re-emphasise that wherever you're from, youth support, children and family services, disability services, if you're working in the end-of-life care scenario, mental health services with addiction teams, we all need to pull together to build a team around the family, to support the family and make sure the children don't care. The mistake, no, not a mistake, that's too harsh on ourselves. The learning curve we went through in England was we set up young carers projects. Services identified young carers, sent them to the project supported the child, and the file was closed. So things didn't change in the family home. For a number of years, we have to be very, very proactive. You have the chance to benefit from our learning and make that giant leap. The project support, but the support in the family home at the same time. And so that we can make sure that young carers are children first, free to develop emotionally and physically, take full advantage of all the opportunities that they should have, just like their peers, for their educational achievement and life success. Because what I haven't said, let's end on a positive note, it all sounds very black, but these children are amazing. They have resilience, they have empathy, they have transferable life skills. Often they don't have qualifications. How can we make sure that they can be the future generation that can give back? And we can do that by supporting them now. And I'll just say, please, my final slide, that I'm here to help Toronto, Hospice Toronto, move forwards for young carers. So thank you for inviting me. I'm sorry I've overrun.
Does anyone have any questions for Ms. Frank or for Chris?
Hi, Jenny. My name is Sydney. I'm from the Toronto Central Health Care Network. I just wanted to ask you a question in regards to the drivers of a lot of growth, the young carers program in the UK. I wonder if it had to do with trends around demographic trends, or if it had to do with physical pressures
something called the National Health Service Community Care Act, where a lot of our institutions were closed down and community was put into the family home. So we had quite old-fashioned mental health institutions. We had nursing homes for people with chronic and life-limiting conditions. Those were closed down, and there was a move to move all the care into the community. And very quickly, people started to realise that this was having a wider impact on the family then, because it was going back into the family home. Day centres still exist, but a lot of them were reduced in availability, because it was felt that if people were ill, why should they have to live in an institution? Why shouldn't they live in their family home? Quite rightly, but there's a knock-on effect to the home. The own drivers for my own work were actually quite personal, because I mentioned I had a daughter with a disability, and her reviews used to take place every 3 or 4 months for our family to have respite care. And a very astute social worker recognised that it wasn't just mum and dad that needed respite, it was brother and sister that needed respite. And she asked me, because she knew I had a background in research as well, if I would do a small piece of research looking at the needs of sibling carers where there's a child with a disability. I started to do that work at the same time as Professor Saul Becker was looking at the needs of parents with disabilities under the Community Care Act. And the two pieces of work were published nationally to great media hype, shock, horror, these children are caring, how can we let this happen in this country? And that's what started the whole ball rolling, really, was the media. I can't say that it was comfortable sometimes, the media, but it really did make me start. But it was a change in the way we delivered services. It's continued to grow over the years, and I think in answer to the last part of your question, is it going to get worse? I think that as a member of the Standing Commission, we are acutely aware, I think, of how technology has moved on, and people, adults and children, who might not have survived a condition or an illness are now being supported to live longer, which is a real positive, but it has an impact on the family caring role. And I think particularly in England, we have a wave of children that are coming through severely disabled, either because they've survived a premature birth, which they might not have done in previous years, or they've been born and they are a result of fetal alcohol syndrome. It's a huge problem in the UK. I'm not sure if it is in Canada, but I imagine it's not just the UK that has a problem. And so we have children, young disabled children coming up now to teenage years with high level care needs that are impacting on families. So is it going to get worse? Certainly as those demographics it is.
Because their siblings are taking care of them.
Their siblings are taking care of them, but also it's an impact on the wider family caring as well for adult parent carers as well. There just isn't enough resources to go around.
I want to ask you in relation to that. I know Dina and I certainly had conversations about the impact of the aging population, especially here in Canada and even in Ontario. I had told Dina that our Ministry of Finance had created some projections around anticipated deaths in the next 25 years, showing that 65% increase in the total number of deaths in 25 years. I wonder, given that, and obviously our population number is becoming inverse, if the issue of the supply of young carers is an issue for the UK. I mean, are there lessons learned that we want to see here?
If I turn that around and saying that if we're protecting children from caring, maybe where we want to be in the future is to have no children caring. This is what, in the UK we have Children at Risk Act, Children in Need Act, and what I'm saying is that in previous years we've been quite shocked that young carers haven't been assessed as children in need enough. They haven't reached the threshold, but I'm saying actually they shouldn't, because if they reach the threshold of being children in need, we failed because we haven't given enough support to the family. Have we as service providers, healthcare providers, failed because we forced that child to care at a level which has impacted on their own development, we've caused them to be a child in need. So I just would like to preface my reply like that. But I can see totally where you're coming from, and we've done some sums in UK, and I'm sure you have in Canada, and I don't have them to cause, but it's something quite shocking. It's something like, at the moment we have something like, for every person that needs care, we have something like 90 people able to provide informal care. But as demographics change, that's going to reduce, and we're going to only have something like 6 or 7 for every person that's surviving into old age, and also with healthcare needs, because the population change. So
Maybe
demographically, that's going to be a struggle. But I would not like to see young carers plugging that gap, because my aim in life is to prevent children.
But maybe isn't that a function of the way we think of family because of what we've had in the last number of generations? We have to change the way we think
We
of
are going
family.
to have to change the way we think.
Yeah.
Totally. Because it's coming, it's not going to change.
So are you saying that maybe you want to get to a point where young children shouldn't be cared?
They shouldn't be caring where it's impacting on their own well-being and their life chances. Every child cares to a certain extent in the family. There's the love, the care they share with their family. There's the just general helping around the home. There's helping out at points of pressure or crisis. But to be caring day in, day out on a level where they can't achieve at school, it's affecting their own well-being and their own emotional growth, then no, they shouldn't. I mean, we have young people, and they come with me and they talk about the situations they've got into where they've turned to self-harm, they're experiencing depression, they're not achieving what they want, and we shouldn't be putting children under such pressures of caring that they are having to experience. But not every child in a family where there's an illness or disability is a young carer. I have to say that, it isn't. And it's wrong for us to be judgmental on the parents, because going back to my earlier slide, it's where we're not putting in enough services, we're not recognising the need that the children are picking up at this. There's something else.
It's okay.
I just have a comment. Would you be able to repeat the questions in the audience, because it's hard for us online people to hear the questions that the audience made.
Okay.
Thank you.
I'll try.
So hi, I'm Melissa. I'm a U of T student right now, and I'm actually a young caregiver myself, so this was really inspiring. But my question is, where there isn't enough resources, have there been programs implemented where the extended family, let's say, gets involved, like maybe able grandparents, able aunts and uncles? Because I know from my perspective, I took all the weight upon myself. I'm the eldest of the siblings, so it was like, I don't want to bother anyone. And so really they don't really know like the dynamic of the family, the dynamic of, let's say, depression, and especially in cultures where that type of sickness is not really, you know, given support. There really needs to be like a thorough understanding. So besides from the government and these acts that have been implemented, have there been programs that allow extended members to get involved and help out?
Yes,
That's my question.
yes, very much. So briefly, the question then is looking at the role of the extended family members. I know you said much more, but is that okay for the people out on the web so that they... and yes, well, in the UK we've adopted family group conferencing, which came over from New Zealand. Are you familiar with that in Canada? It's actually a Maori tool, and the focus of the conference is the child. So if there's a child that needs support, they actually bring the whole family together, and they look at who in the family could maybe support the child. We adopted that to actually look at who in the family could support a person with the illness, the disability, and the care needs. So bringing in grandparents, maybe bringing in faith groups to church, bringing in friends and neighbours, and sharing out the tasks that might be needed to be in home. But the crucial thing about that family is that the family group conference is the Maori model, is that it runs in 3 phases. So first of all, you meet with all the professionals and the family. They're all in one room, and they talk about the needs and the issues from a professional viewpoint. Then all the professionals have to leave the room and leave the family to talk about what they want to, because there are things they may not want to share with the professionals, and they have to come up with a proposed solution. This is where I'm talking about a child being at risk. They then, when they're ready, call the professionals back in and say, this is our solution. You'll spend the weekend with the grandparents, or the grandparents will come and help do the caring for every Tuesday. The neighbour down the road's offered to do the shopping. Somebody else is going to take the younger children to school when mum has a bad day. This is our plan. Are you happy that it's going to keep the children safe? And then everybody signs up to it and it's reviewed. It's a very, very strong, cost-effective model. Happy to talk about it more after the webcast if you want. And we're taking that forward in the previous slide that I had about the team around the family now. So you remember I said we all need to be working together, youth support, team services. So it's about an early point of diagnosis, when you first know that there's a family member that's ill and they've got significant care needs, calling a meeting for the whole family and letting them talk and seeing who needs information at what level. And obviously an 8-year-old child's going to need information at a different level to a 14-year-old. Making sure everyone's got all the information they need to cope and to move on and keep their family life as stable as they can. So family group conferences, but also team around the family is very much that circle, the green circle that I showed you on the slide. That's very much where our Department of Education wants to go, is building a team around the family, bringing everything together. And of course, in these days of credit crunch, I keep saying, well, this is the golden opportunity. Let's not work in silos. Let's not have a worker for the adult and a worker for the child and somebody else doing all the health things. Let's have one team around the family with one person leading. Let's share the budget and see if we can save money but get resources at the right time. You know, this is an opportunity. So, does that answer
Yes, it
your
does.
question?
Thank you.
But
Yeah.
family group conferences, if you don't know about them, I'm happy to talk in more detail and put you in the right direction for information. They're brilliant.
Thank you.
I just wanted to add to that. I'm from Hospice Toronto, and one of the reasons that we developed the model was because it was such a perfect fit for our existing Kit for Kids program, which supports children in a home where someone's dying. The hospice model provides volunteers that support a family member when there's a death, and sometimes that's volunteers, but sometimes that's family members and friends. And often we support large teams of up to 20 or 30 family members and friends. So the fit for that was incredible. The other thing is the advisory committee for the Young Cares model is made up of organizations in Toronto that will include Alzheimer's, ALS, the MS Society, children's organizations, Ronald McDonald House, I'm Hoping Sick Kids, Bereaved Families of Ontario, CAMH Mental Health Services. So it's a very holistic model that then can put the supports around the family in a hopefully a true shared care model that makes sure that the children are not, as Jenny was saying, not caring at all, but that when they reach a threshold where that caring is impacting their life, that there's awareness of that and supports put in place to not only support the family unit through formal and informal caregiving, but also to support the child to flourish. And the rationale for that is that the long-term impact on the healthcare system when they fail to thrive and potentially end up in mental health or physical health breakdown that impacts the system in the long term. So that's just a little context around how the model actually at end of life works to work in a partnership model that does bring services into the family.
Thanks, Tina. That's really helpful, I think, for everybody to hear. So my last slide, moving forwards for young carers, is moving forwards the pace, I think, for young carers, because that sounds just like the perfect model. And I know you shared that with me yesterday, but it's much better than you say it. I'm not going to be able to repeat that for the webcam, but I hope people heard it.
And Sylvia, this is Sylvia Bago, and Sylvia started a program through the Aging in Home strategy in Niagara. And so we borrowed off a little bit of her work. And I asked her to tell a story just before we close, because this was the reason that we started the program. And it spoke to the impact on young carers. And it was a family, I believe, Sylvia, where the adult in the family had Alzheimer's.
That's right. Yes. Yeah. Yes, I was actually working as a family support counselor with the Alzheimer's Society of the Niagara region. And we had noticed in our work that there were many children in these families who were providing care for the person with dementia. And many of these children failed to thrive. We noticed this, but what really drove the project forward and what actually started us in our Young Carers initiative here in Canada was one case where we had at the time tracked 78 children on our caseload who were providing care for somebody with dementia. And these children were invisible. But this one case, there was a single mom living with her mother who had developed dementia in the past several years, and two young children. One was a 13-year-old girl, and there was an 11-year-old boy. And the single mom had to work in the evening to put money on the table. And the children came home after school, and they cared for grandma. And their loving grandmother that they had lived with since they were very small had turned into some different personality where she could be abusive with the children. She would curse and swear at them where she never used to curse and swear before, was always loving and kind. They found that emotional component very, very difficult to deal with, besides having to look after her, get her supper, help her do her toileting, get her ready for bed, and all the while she would be abusive with them. So we were working with the family trying to sort out some solutions. And the young girl at 13 took Marge Dempsey and myself aside, and Marge Dempsey at the time was my supervisor. She was the director of family support services. So the young girl took us aside when we were having this family meeting, and she said, "I really need to talk to somebody." And she said, "I am just beside myself with this situation, and I don't know what to do." But she said, "I was trying to figure out a solution, how I could make things better." And she said, this is the only thing I could think of." She says, "I could kill myself. That would be a way out," she said. She says, "Or," she said, "I could kill my grandmother. That would be another way out." And she said, under the Young Carers Act in Canada, or the Young Carers Act, I'm sorry, under the Youth Offenders Act, she said, "I'd probably only get 3 or 4 years in jail, and then I'd be free." And that's how desperate this young girl was. She still loved her grandmother, but she just could not cope any longer with the situation. It had gone beyond where it could be, where she could cope. And so we had to, declare this situation an emergency and move quickly to get alternative levels of care for the grandmother where the children were not required to look after her. And that was what prompted us then to start a project. At first, it was only directed at children in dementia care families, but when I started doing research to do a literature review, that's when we ran into the Young Carers movement in Britain. And we came, and then we decided to expand our horizons, and we started a network. We had 17 different agencies on that network that came together to start our own Young Carers initiative. And Jenny, I met her, fortunately, in 2006, came to our first Young Carers conference in Canada as our keynote speaker.
And so brutality is an end of life here, where especially illnesses are being extended through drugs and therapy. Families are living with those conditions longer. And so that is not an unusual story. I can tell you that in the last couple of years in Hospice Palliative, we've had family situations where the level of crisis was not significantly different in that story. And so you're seeing the stress on the family unit and the impact of creating resiliency
really a huge issue. Another case that we had was a little 6-year-old boy who lived with his single mom and grandmother who had dementia. And this little 6-year-old, I heard his mother tell him one day actually that he was the man of the house. And he had to do, look after the dog and help his grandmother do various things. And he was the little man of the house. He went to school one day and in grade 1, he was so angry he took a pair of scissors and tried to stab his teacher. So we had a big meeting with his child psychiatrist. And all the agencies that were involved in that family, there were 27 different agencies involved in one family to help address this young child's needs. And so there has to be, I think, a better way of doing it. There really has to be. Now, his grandmother had dementia, his mother had rheumatoid arthritis and was on morphine for the pain. So, yeah, very, very difficult situation. But for 27 different agencies to be involved, very expensive on the system. Very expensive.
Thank you, Sylvia. I think I'd like to just echo that often there are families where there's more than one person requiring care. And so, those stories that you shared with us are really illustrative of young carers around the world. I guess we need to finish off, so can I just say a couple of words? Just kind of going back to what we were talking about, the circle around the family, I think the important thing for me as well is to remember that families function in different ways, and whatever we're doing, we need to start off by recognising the family's strengths no matter what, and building on those strengths and supporting them in a way that's comfortable for them. And that includes looking at cultural needs, because I think if we start off by doing that and we get on the right foot, families don't feel invaded or being told what to do. It's about recognising where they are, how they're coping, what can be added. Absolutely vital, I think. And I would just really like to finish off by saying thank you so much for listening to me today. I hope I haven't rambled on too long. It was really interesting to hear Chris, and I'm going to be talking to him afterwards as well. But thank you to Hospice Toronto and the sponsors who have actually enabled them to start this piece of work for young carers. I think what's particularly exciting for me is I just feel you're going to leapfrog across quickly, so no pressure there, Larissa, because I know that the model that you're hoping that you are going to be developing in Hospice Toronto, the funding is going to enable you to use that model to be replicated across Canada to help other locations across the whole country of Canada. So very exciting that stone thrown in the water. Oh, in Niagara, how about that? It's true. Not that big waterfall, just a little stone. Has rippled out to Hospice Toronto and is going to ripple out across the whole of Canada. So I'm very, very excited, and thank you, everybody.
Project starting in British Columbia now.
I'd like to let everyone know that our sponsors today have also supplied a reception. So in that door in the back of the room, please feel free to stay and have a drink or something to eat. Thank you so much for coming today. And I would like to thank our special